Good morning, everyone. And today, our topic of discussion is antiphospholipid antibody syndrome. This one is mostly written in association with systemic lupus erythematosus, but not a very long topic, a short topic, but I am discussing it as a separate topic because it can occur in multiple settings. So, first of all, to start with the definition, um, what is antiphospholipid antibody syndrome? So it is defined as multi-system vasculopathy, uh, many manifested by recurrent thromboembolic events, spontaneous abortions, and thrombocytopenia. Now, this is a very important topic from gynecology point of view as well, because they have spontaneous abortions. One of the cause of recurrent abortion in the females, and what happens in this one? Basically, there is circulating antiphospholipids, uh, antibodies or autoantibodies, okay, which interfere with coagulation. So now one thing is clear, like there is thromboembolic events, right? One thing is clear, there could be spontaneous abortion, and one thing can be clear, like there is thrombocytopenia. To talk about the pathophysiology, I'm not going to take a lot of time. I explain you the pathophysiology of SLE, and then what happens in SLE is like um, the antigen presenting cells, basically the cells which are uh, done by apoptosis. Um, like the antigen presenting cells, they started presenting their antigens to the body immune system, and they started making autoantibodies. So what happens, like in this condition, in antiphospholipid syndrome, what happens is there is negatively charged phospholipids and beta glycoproteins, uh, which are present on same like on the apoptotic blebs, and what you can say, and that's why it is believed that antiphospholipid syndrome is it arises by the same mechanism as what, like how lupus autoantibodies are formed. So what is there, like simply a negative charged uh, phospholipids, as well as um, beta 2 glycoproteins, okay, they are present uh, on the outer surface of apoptotic blebs, okay. And when this thing occurs, simply um, there is autoantibody formation, right? So of course, like this is the same mechanism how um, what you can say, systemic lupus erythematosus, it occurs. Now the important thing over here is what in the body there is basically presence of autoantibodies, okay. And what happens is, like simply when there is autoantibodies in the body, um, uh, this causes multiple events like thrombosis, both arterial and venous, and whatever like we discussed, like spontaneous abortions, okay. So now what it is like classified, simply we classified this condition as um, primary antiphospholipid syndrome, or secondary antiphospholipid syndrome, and sometime the third kind is also there, catastrophic. Catastrophic, of course, like which is a severe form, antiphospholipid syndrome. So basically, if we will talk about the primary APLS, guys, what this one is, when there is no underlying disease, right? And it is present in the patient when they don't have any other condition, so they just have this antiphospholipid syndrome. And the secondary one is simply when it is secondary to some condition, for example, connective tissue disease like SLE, okay, which we had already discussed, right? So SLE can cause this thing. Or, for example, if there is underlying malignancy, and it is the thing, or someone who had this thing as a result of drugs, like the drugs will remain same, like hydralazine, procainamide, and isoniazid, and drugs like this, phenytoin, which I already discussed in drug-induced lupus. And infections, for example, infections like HIV, as well as TB, or you can say hepatitis, right? So this thing can occur. And catastrophic antiphospholipid syndrome is basically when there is, you can say, development of thrombotic occlusion, okay, in small vessels, okay, um, within small vessels within 1 week, or there is three or more than three um, organ systems with positive, um, what you can say, antiphospholipid antibody, okay, antiphospholipid antibody. So this one is basically like there is very high mortality in these patients, okay. So this is like that's why it is called as catastrophic antiphospholipid syndrome. So now, guys, the important thing is what are the clinical features, simply, if you know what's going on in this one. So simply, there is the clinical features. We know, like, what's going on is they have thrombosis, right? And they have like recurrent abortions, okay, and they have thrombocytopenia as well. So what will be the clinical presentation of that thing? Of course, we are going to discuss that thing. So simply, due to thrombosis, what can occur in these patients? Thrombosis, what is going to occur in these patients is, of course, they can present with stroke, okay. You can say they may have multi infarcts in the CNS even, okay, and it can lead to dementia. They can have myocardial infarction. They may have limb ischemia, okay. Um, so simply, like, see, these are all the consequences of thrombosis. They may have DVT, okay, and that's why, all these conditions, whenever someone has DVT or things like this, so we check for the antiphospholipid antibodies. Simply, this is the reason. They may have retinal vein thrombosis. They may have renal thrombosis, okay. So see, all these are the consequences of thrombosis. And recurrent abortion is simply, they have a fetal death, okay, and mostly like more than 10 weeks of gestational age, or you can say mostly in the end of first trimester or in the second trimester, okay. So what you can say, other thing is, they have recurrent abortions, and also premature births, okay. So these are the things which they had. And of course, like, because they have um, thrombocytopenia, so they have what you can say, multiple superficial bleeds as well, okay. So this is also one of the thing. And also one of the clinical feature which they present with is migraine type of headaches, okay. This is also a feature of this condition. So they have like this thing, and also, like, there are other things, they may present with pallor, Because of hemolytic anemia, they may present with Raynaud's phenomena. I told you already about this one. Okay, so Raynaud phenomena they can present with. So superficial bleeds like purpura can occur. Okay, or petechias can occur, as we know. Okay, also they may have gangrene due to limb ischemia. So of course, like all these features are the clinical features of this condition. So, in gynecology, if someone have recurrent abortions, they also check for this syndrome. Anyone who have DVT or any thrombosis, they also check for this thing. So, and of course, because they have multiple infarcts, it can result into epilepsy as well. Okay, or seizures, you can say. Seizures can be there. Okay, so simply all these things can be the clinical features of this patient. And as I told you, it can lead to have catastrophic results, which is called as catastrophic APLS. I already told you what is the diagnostic criteria for that. uh, Talking about what you can say, um, how we diagnose this condition, right? So simply, you can say the labs which we do in this, or laboratory diagnosis, can be done when someone is presenting with these features, or sometimes it comes as a screening result. So simply they have uh, what you can say, anti-cardio lipin antibodies. Okay, both IgM and IgG. They have anti beta 2 micro or glycoprotein 1. Okay, antibodies. I already explained this thing, right? And they may have ANA, of course, when it comes with association with SLE. So they may have and even without SLE, many of them, they have ANA positive, like they have anti-nuclear antibodies positive. So simply, anti-cardiolipin test, it can detect both IgG as well as IgM antibodies. Okay, so basically, uh, this is the antibodies which bind to the negatively charged phospholipid, cardiolipin, which I told you they are circulating in the in the blood, right, in these patients. And this one, anti beta 2 glycoprotein 1 antibodies, you know these will detect the antibodies which are going to what you can say, bind to beta 2 glycoprotein. Again, I told you they are circulating in the blood. Oh, by the way, this one is 1 type, right? So the same thing we are going to detect in these patients. So the thing is, uh, one of the tests we do is, we call it as lupus anticoagulant test. Okay, so what they do, uh, this is like how when they check the ability of the blood to clot in the test tube. Okay, this one, it contains the name lupus, but basically it is not a test for lupus. It is a test for antiphospholipid syndrome, right? So um, what happens is, like uh, they add the normal plasma in the blood, and they see like if the prolonged APTT, prolonged, sorry, because they have the platelets are decreased, so they may have um, increased activated plasma thromboplastin time, right? APTT. So APTT uh, is not corrected when we add the normal plasma in their, what you can say, in their blood. So you can say the prolonged APTT prolonged, which is the prolonged, is not corrected by addition of normal plasma. Okay, so like normally it should be corrected, but in this patient, it is not connected. It is not corrected. So this is the test we do. Uh, what you can say, um, like these are the tests, which we can do to diagnose these patients, right? And this syndrome, it comes in association with um, SLE, SLE patient. That's why you will find this syndrome written with SLE. So now, how we diagnose or say that someone have antiphospholipid antibody syndrome is simply when we test the patient on two different occasions, like 6 weeks apart, and we found like positive blood test, for these things on two different occasions. We like it is enough to diagnose the patient with APLS. So because like many people who are like tested positive for antiphospholipid antibodies, they never get antiphospholipid syndrome. Okay, so not all antiphospholipids are harmful, you can say, but like these are basically the one which are harmful. Okay, so when we diagnose, like to diagnose, we need like the presence of these things in the blood. Okay, so now the important thing in the treatment for these conditions is simply, as we know, like there is thrombosis going on in the patient, right? So of course we have to treat the thrombosis. Okay, we have to do something for the thrombosis, as well as in the gynecology or gynecological management is different, because like of course these are the females which will having recurrent loss of the fetus, and there is the management of catastrophic uh, type of antiphospholipid antibody syndrome. So for thrombosis, guys, remember when anyone have any type of thrombophilias, okay, so we put them on lifelong anticoagulant, like in this case we can give them warfarin. Okay, so we put them on warfarin lifelong, of course. And the target INR which we have to achieve in these patients is to keep their INR, international normalized ratio, between 2.0 to 3.0. Okay, uh, especially in the patients who have recurrent thrombosis, we put them on lifelong warfarin. Uh, in gynecological patients, anyone who have diagnosed APLS syndrome, or like of course this is diagnosed when someone have recurrent miscarriages. So we put them during pregnancy, we put them on low molecular weight heparin. Okay, uh, with or without um, aspirin. Okay, so like of course the gynecologists, they decide. So whenever they get pregnant, we put them on this thing, low molecular weight heparin, with or without aspirin. We don't put them on warfarin simply, guys, because warfarin is teratogenic. Okay, and anyone who's developing catastrophic APLS, of course the high mortality is very high, so aggressive treatment is needed. So what we do, we give them high dose of steroids, as well as we give them anticoagulation, and we have to suppress their immunity, so we can give them cyclophosphamide. Okay, or if the condition is very 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 bad and you can say uncontrollable, you can go for plasma pheresis. Okay, so plasma pheresis is the choice, or you can say the uh, simply in emergencies we can go for this thing, plasma pheresis we can go. So now of course, like depending on how the patient present, like if the patient is presenting with thrombosis, we do a thrombophilia screening, in which we check different things. One of the things is we check for antiphospholipid antibodies, and whenever like it come back as positive, we put them on warfarin. Okay, and warfarin is a different topic itself, because we have to maintain the INR in this range, because if INR will drop below this one, they go into hypercoagulability. If it is go above 3, so there is risk of bleeding. So uh, why we put the patient on low molecular weight heparin? Because it can be taken as a subcutaneous dose, and there is no need of monitoring while taking low molecular weight heparin. Okay, so simply it reduces the chances of miscarriages, it reduces the chances of preeclampsia, but poor fetal growth remains common with this treatment. So this thing, and but I told you about warfarin, we cannot use this thing, and of course catastrophic APLS need aggressive treatment. So this is how we treat mostly all the auto antibodies things, in emergencies. So guys, that's all about APLS syndrome. And the important thing in rheumatology is there is just few of the topics which are left, and hope so in the next 2 weeks we are going to finish them. Like I'm planning to have lectures about um, systemic sclerosis, okay, as well as gout, okay. So I will be talking about next week maybe about systemic sclerosis with gout, and other than that, there will be one lecture about ankylosing spondylitis. Okay, so next week we will discuss the ankylosing spondylitis, and with some other topic like maybe we will choose some, what you can say, um, some of the other topic from rheumatology. As I told you, like here in our university, they just teach two topics, SLE and rheumatoid arthritis. But I think it's better to um, read or to know about more conditions. Okay, rheumatology is a very what you can say developing field, and now yes, one we can include psoriatic arthritis, with that one. So we can include psoriatic arthritis with ankylosing spondylitis. So that's all. So I hope you understand this topic. And yes, and one more topic which we are going to include is polymyositis and dermatomyositis. So once we will finish this, of course, if we have time, we can discuss some other like small topics, not so important. Like they are important from you can say MCQ's point of view, especially for the exam like USFLE or PLAB exams like this. They ask questions like this in those exams. So thank you so much, guys, for listening.